Very good morning, everyone, and welcome to our first breakfast at FOM seminar this morning, the 6th of January 2020 and 21. Happy New Year to everyone. And I'm delighted to be able to present our first speaker for today. Her name is Professor Dr. Chan Yu Kuen. She's an obstetric anesthesiologist from the Department of Anaesthesiology in the University of Malaya. She basically fell in love with the subspecialty of anesthesiology over 35 years ago and has continued her love in the discipline over that period of time. And she has written extensively in various books and publications and has been very involved internationally in the discipline of anesthesiology. She's going to share with us her particular expertise and interest today on the topic of a topic in this field, and her title for the presentation is Two Lives, the Anatomy and Physiology of Death. She'll be presenting for 25 minutes and there'll be 5 minutes for questions and answers. Please feel free to use the chat box in the Zoom webinar to ask any questions to Professor Chan. So I will hand over to her now as she shares her expertise and talk with us this morning. Prof. Chan.
Thank you, Prof. Lam, for the very kind introduction. I'm going to share my screen with you now. All right. Okay, Prof. Lam, yes, I have fallen in love with anesthesia, but it is also into the subdiscipline of obstetric anesthesia that I've fallen in love with. And because of this subdiscipline where two lives are involved, I am going to highlight for you the anatomy and physiology of death in these two lives. Well, it is probably a bit of a morbid subject to start the year off, but it is actually by knowing death that we can understand lives. And I've got no declaration of conflict of interest over here. All right, we'll start off with the death of my mom, which I would describe as being beautiful as in a way. My mom died at the age of 80 following a fall. And in her youth, actually, she was very beautiful, but she lost some of her beauty to wrinkles, of course, at the age of 80. And in her deathbed, my sister and I were very lucky to be there when she transitioned from life to death. And we were very comforted, especially when my cousin visited 2 hours later and remarked that in death, my mom had become more beautiful. And the physiologist in me couldn't help but explain to this relatives of mine how the sodium had actually moved into the cell because the sodium-potassium pump was no longer working in the absence of oxygen to the cells, and how water had followed suit and then caused all the cells to swell and erased all her wrinkles, thereby making her more beautiful. However, I can't but describe these two obstetric deaths as being ugly. And why were they ugly? Because they happened to have affected two very young ladies in the prime of their lives. And because the lifespan of our country is about 70-something, I would say that they have actually been robbed about 40 years of their life. And the first happened to be a single lady with an intrauterine death at 32 weeks. And she stayed away for 2 weeks. So when upon arrival, she had roaring sepsis and she collapsed and could not be resuscitated. And the other patient was a foreigner who was working with the husband about the intricacies of how to get into the hospital itself, because her husband at that time, being a contractor, was about 200 kilometers away. And what happened is she decided in the end to deliver her own baby, but she ended up with a dead baby and arrived in the hospital in a very exsanguinated state and could again not be resuscitated. Now, every year around the world, there are many maternal deaths in similar circumstances, and most of these deaths are due to the fact that these mothers have arrived very late, or worse, they have arrived into hospitals where proper definitive care has not been made available to them. Equally, there are 2.6 million stillbirths worldwide as well. In fact, these poor fetuses or unborn babies have actually been even robbed of a life on Earth. That means they've never experienced what it is like to be alive on this planet that we all have grown to love. So in the next 20 minutes or so, I'm going to try as an obstetric anesthesiologist to help you look at the anatomy and physiology of these deaths. And I'm going to highlight for you and to help you recognize some of the physiological principles we actually need to know to ensure these two lives continue to its full state. So what is it that keeps us alive? Do we live to eat or eat to live? Obviously, we eat to live in order to bring energy sources into our system. Energy is actually the basis of life. And that energy that we need to sustain us is in the form of ATP. And all energy actually, if you consider, has to come from somewhere, and the only source of energy in the world is the sun. And that energy is actually captured by the process of photosynthesis. And we have energy sources from plants and probably indirectly from animals that eat these plants, and then we ingest it. And together with oxygen, this is actually brought to the cells and then into the mitochondria, where energy conversion from the energy sources in the presence of oxygen to ATP takes place. Now, in the presence of oxygen, the ATP production is remarkably high compared to in the absence of oxygen. So it is actually very important for us as providers to understand that all of us need oxygen in order to efficiently convert the energy sources into ATP that our cells need. Now, there are two types of oxygen users: the oxygen conformers or the oxygen regulators. Now, the conformers are those animals that are hibernators, where in the absence or in the state of reduced supply of ATP, the demand also goes down in parallel. We, however, are oxygen regulators, where when the supply comes down, our demand does go down a bit, but not as well as those of the oxygen conformers. So there will be a gap between demand and supply, and that gap is described as energy failure. And energy failure as a concept is actually a very important concept to recognize, because this gap or energy failure is the forerunner to tissue damage as well as finally death. In fact, the concept of energy and energy metabolism has also slowly but definitely crept into the obstetric literature, as you can see here, and that was in 2012 by this team headed by Murray. I'll be referring to this article again in a short while. So we did say that energy is important, but we don't have to actually ingest food all the time, because we have got a good storage organ in the form of liver, so that we only need to take food on probably 3 times per day basis. However, that cannot be said of the same for oxygen, because there's no storage for oxygen and a constant supply is needed. And that supply has to be ensured by us as humans or by providers in the form of a patent airway by the process of breathing. And that oxygen is actually taken up in the pumped around by the circulation. Oxygen is actually combined with the hemoglobin in the red blood cells and finally brought to the tissues and into the mitochondria. And this is the process that we have to actually focus on, especially if we are to sustain life of our patients. If you look at the pathway of oxygen, it passes through the airway by the process of breathing into the gas exchange site in the lungs, into the circulation, and then carried in the hemoglobin and then into the tissues. And any of these processes, if it is obstructed or not functioning well, can mean the demise of the patient. And globally, if you look at maternal deaths, you will find that the big killers in the maternal population would be hemorrhage, hypertensive disease, as well as sepsis. Now, you can actually consider hemorrhage as a situation where you have failed hemoglobin and resulting in failed oxygen delivery. And for hypertensive disease and sepsis is actually failed microcirculation, again resulting in the cells not being able to get oxygen into the mitochondria itself. Obstetric anesthesiologists, we can't influence the this part of care, meaning the part before the patient arrives, because these are the work of the epidemiologists and all the care providers in primary health. And we are usually at the terminal end of definitive care. All right, but having said that, if we are aware that the patient is in need of our care, we can actually still put strategies in place to ensure that the care that they're going to receive will be arranged properly to receive them. And most times when patients are in distress or in trouble, we actually would like to get to them early because oxygen delivery is actually a time-sensitive event. And in many parts of the world, the early warning systems has actually gone into existence all around the world, especially in the United Kingdom. And in the obstetric population, Dr. Singh in 2012 as well has modified the early warning systems into the modified early obstetric warning system called MEWS, to ensure that this population of patients also get to be recognized as being high risk when they have trouble getting oxygen at the tissues as well. Similarly, we have actually converted in the last 20 to 30 years from general anesthesia as a way of providing anesthesia for parturients, because general anesthesia is more risky than regional anesthesia as a life threat. In fact, if you look at this data from the United States, you will find that anesthetic-related death has actually come down. When I was actually a medical officer in the 80s, general and anesthesia-related death was the fourth highest ranking cause of death around the world. All right, and we have now got it off the 10 leading most contributory cause of death in the obstetric population because of the use of regional anesthesia. However, again, data from here shows that regional anesthesia is also now a cause for concern because the case fatality rate following regional anesthesia is slowly creeping up as well. So if you look at pre-1990, comparing it with the post-1990 data, you will find that maternal and fetal death has definitely come down as a result of that particular conversion I was alluding to. Now, when general anesthesia was used at the height of the 80s, the cause of anesthetic-related deaths was due to airway problems. We call it failed airway and failed ventilation. Now, currently, when you look at regional anesthesia being used more widely, these green arrows show that the figures for failed airway as well as failed ventilation coming down, but now the cause of maternal death has gone into failed cardiovascular system. All right, these patients are having cardiac arrest following the neural axial block or high neural axial block, which again can threaten the cardiovascular system. As an obstetric anesthesiologist, it is also imperative for us to sustain and be aware of how to sustain the life of the fetus in utero. And this, I must admit, is my only publication, at least a venture into publication in Lancet itself. And it is very important for us to recognize that this oxygen that the tissues of the baby gets is also from the same plants that we all get oxygen from. But the difference is that oxygen has to pass through the mother, through the placenta, into the umbilical cord, and then into the cardiovascular system of the fetus before it can be distributed to the tissues of the fetus. So it is definitely a longer pathway for oxygen delivery to the tissues. And because of that longer pathway, you will see the disparity in death between mother as well as the fetus. Now, every year, about 500,000 mothers die annually from perinatal oxygen deprivation, whereas there are about 3 million stillbirths every year in the world arena. And if you look at category 1 cesarean section, these are the life-threatening situations where caesars are considered, and you will find that the life threat is more for the fetus than for the mom. So I would say energy failure is more responsible for fetal, for the level 1 urgency cesarean section. Again, this is reflected in the way the baby needs to be resuscitated in level 1 urgency, and energy failure that needs to be attended to by the care providers when these babies are delivered. Well, life in the fetus or as the fetus is actually very tenuous. The oxygen saturation in the fetus is only about 70%. So I think I would not be wrong in considering that all fetuses in utero experience hypoxia. Now, many of us who are associated with care of the newborn recognize that they have a very high hemoglobin of 16 grams per cent or so. And that's actually a compensatory mechanism for hypoxia. And they have fetal hemoglobin with a high affinity for oxygen, again for the same purpose. Now, I think there are many of us who are not aware of what is meant by the double Bohr effect as another evidence, and the circulation being redesigned to better flow to the brain as yet another mechanism to explain or to compensate for the fetal hypoxia. Now I'm going to elaborate on item 3 and 4 here. Now, what exactly do you mean by the double Bohr effect? Now, as I said earlier, the oxygen dissociation curve of the fetus is to the left of the maternal oxygen dissociation curve. When the fetus empties carbon dioxide into the mom, the oxygen dissociation curve of the fetus moves to the left, and the oxygen dissociation curve of the mom now moves to the right upon receiving the carbon dioxide. This is the Bohr. So it's a double Bohr effect on one side here and on the other. And this increased gradient is actually responsible for the greater oxygen diffusion from mother to fetus as another compensatory mechanism. Now let's look at the fetal circulation. Whenever all of us are hypoxic, our cardiovascular system redistributes blood away from the non-essential organs to the essential organs in the form of the heart as well as the brain. And if you re-look and reflect on that blood flow in the fetus, you will realize the oxygenated blood comes into the right atrium, goes into the left atrium, left ventricle, and then of course the first organ would be the coronaries, and then it goes into the brain. And this might just as well explain why by term 95% of the head of the fetus is actually presenting. In other words, the cephalate presentation is possibly a reflection of the greater flow of oxygen, greater energy availability, as well as greater density to account for the 95% cephalate presentation in the fetus. Now, this is the article that I was talking to you about by Murray, where he actually studied babies and the situation in low altitude as well as high altitude. He found that the oxygen delivery was higher by, of course, compensatory mechanism in the high altitude mothers. However, they were compensating for the hypoxia in these high altitude babies or fetus by reducing the demand or reducing the oxygen, glucose or energy consumption. But no doubt they actually have energy conservation here, but you can see that the ultimate birth weight of babies born at high altitude are definitely lower compared to those born at normal altitude. All right, so this is yet another compensatory mechanism to account for the further hypoxia one sees in high altitude parturients. So it is very important for us to recognize, especially towards term, that the oxygen delivery to the term fetus is even more tenuous. And I would like for you to actually go back to the times in 2018, where some of the boys from Thailand were caught in Chiang Rai in a cave, and the oxygen levels were slowly decreasing, as well as the water level was rising. The whole world was actually focused on that. And in fact, every baby that delivers near term or is near term actually goes through that state where the oxygen levels can be low and be life-threatening. And what happened was at the time when they were rescued, they were all given air bottles. I believe oxygen was inside and masks as well. What I'm trying to emphasize is I do recognize that some pediatricians are fairly hesitant about giving oxygen, even to level 1 urgency newborns. And I do get very flustered when I recognize the need for oxygen. And occasionally as well, there are untrained providers in the form of house officers who manage these patients and who may not recognize what needs to be done. And as a medical legal expert witness, I also see the tragedy that has accrued from this failed care that some of these newborn babies are accorded with. And this is actually the making of a lifelong tragedy for all these babies. Now that we have transitioned into regional anesthesia, we have always been teaching our care providers as well to recognize how to improve oxygen delivery to the fetus. And since 1990, we have actually asked for all our care providers to make sure patients do not have aortic cable compression by turning them onto the left lateral position, either by displacing the uterus to the left side or with a wedge to actually ensure that the aorta is not compressed. And in all critically ill patients, we should encourage them to be turned to the left lateral position and be given oxygen. And of course, in a cardiac arrest situation, do remember left uterine displacement. In fact, this is a very interesting article as well. Stacy, in a retrospective study, was looking at maternal sleep practices, especially for those who had stillbirths. And she noted that in the category of parturients who had stillbirth, in the 1 month, 1 week, 1 day period before the stillbirth occurred, they were more likely than the normal delivered babies to be sleeping in a non-left lateral position. And this, in fact, has warranted an editorial from BMJ as well. So we should, whether the facts are in or not, encourage all our mothers, if possible, to sleep with a left lateral tilt or displacement of the uterus to prevent aortic cable compression in order to reduce or oxygen deprivation for the fetus. And of course, we have the classification of urgency of cesarean section, and you will see that level 1 urgency, which I was alluding to, is immediate threat of life either to the woman or the fetus. And as I mentioned previously, 90% of this is usually threat to the fetus. And if you now recognize oxygen deprivation as well as energy deprivation being the basis of it all, you will recognize that these situations should be prevented or provided with care that is appropriate. And that means giving oxygen and energy in whatever ways we can to the fetus. All right, besides left lateral tilt, there are many things that we can do as obstetric anesthesiologists as well, and make sure that we get the baby out as soon as possible and administer oxygen where oxygen states have been threatened in these babies. You'll be surprised, but emergencies are more prevalent than elective in a 24-hour period. In fact, in every hospital around the world, emergencies are more abundant. And these are newborns of emergencies compared to elective, and energy failure is more likely to be present in the emergency cesarean section babies. As you can see, asphyxia is 3 times more prevalent, with the need for resuscitation again 3 times more prevalent, and the ABGAR score of these babies are definitely significantly lower compared to their elective counterparts. Okay, now this is a very interesting slide as well. It is actually not my husband, not my boyfriend, but a stranger. And what attracted me to him was the fact that he was wearing a t-shirt that says, "Let me drop everything and work on your problem." And that's exactly the message I want all of us to be equipped with, where oxygen and energy states are under threat. So in summary, what I have actually been trying to share with you is I've really focused on death, yes, because it is an easily measured endpoint, because it's the tip of the iceberg. Hypoxic damage, which is the submerged part of the iceberg and is also reflected as energy failure to a certain extent, is just as bad, if not worse. And oxygen and energy delivery is actually the basis of life-focused care. And you would agree, oxygen is an enabler of greater ATP production, which our cells need. Oxygen delivery to the fetus involves a very much longer pathway, and that explains the higher risk of death in stillbirths, in the form of stillbirths compared to mom. And timely, appropriate care ensures maternal and fetal survival. So while Black Lives Matter, we are also going to request for all of you to understand 2 lives matter in this case. And we hope that everybody who has to deal with mom and fetus does something right for them. And since this is the beginning of the new year, may I take the opportunity to wish all of you Happy New Year, Happy 2021. Let's hope that this year will be COVID-free very soon and we can start enjoying ourselves. With that, I would like to thank you for your attention.
Thank you very much, Professor Chan, for sharing your knowledge and expertise in the area. I think it's a very timely and very useful reminder as well on the physiological basis of life and the energy deficits that you referred to in relation to supply and demand. It's very relatable too, and I think it's probably applicable to all our areas of medicine generally, in that they are core building blocks of life. The delivery of oxygen, since we have no stores, and delivery of energy sources as well, in order that our cells can maintain themselves and survive. We have one question on the question and answer panel. It's from Professor Christopher Boy. His question very much is, why do you think regional anesthesia is now associated with higher morbidity? I'm not sure whether he refers to regional anesthesia in comparison to what, but I just wondered what perspectives you had in relation to that.
Well, the thing is, compared to general anesthesia, regional anesthesia is definitely safer in the sense that airway and breathing management of the obstetric patient is actually 10 times more difficult compared to the normal patient. Managing the cardiovascular system of the parturient is not as difficult, in the sense that all one needs to do when doing regional anesthesia is to understand that the mother is still in control of her airway and breathing. And all one needs to do for this cardiovascular system control is to make sure there's a left lateral tilt, 2 good fluid lines, as well as get our cardiovascular drugs ready to be given and administered when is needed. Now, the slightly increased risk that we have been seeing compared to previous times with regional anesthesia that we saw in the US data is because a lot of providers sometimes fail to recognize the cardiovascular compromise can be quite rapid as well. They think that it is safe because we don't have to manage the airway and the breathing. But the cardiovascular compromise, one has to be alert as well. It's easy to deal with, but can be so rapid that, you know, I have seen personally in my 30-odd years, patient losing consciousness. Of course, they will lose control of the airway and breathing as well, and very rapidly as well. And I've seen one patient, because of the cardiovascular collapse and the failed oxygen delivery to the brain, throwing a fit as well. And I almost threw a fit myself when I recognized that. And all one needs to do, of course, is to increase the fluid, give a cardiovascular, give a vasopressor agent and bring the blood pressure up, and everything will go back to normal. I hope I've answered Prof. Chris Boy's question.
Thank you very much. So it's the non-airway aspects in effect.
Yeah, which I was trying to emphasize, but you can see that even these have arrived at a state where it can be a life threat to the mother, and we've seen collapses that, you know, can be very massive as well.
Yeah, thank you very much for that. I'm just very conscious of the time. It's 8:32 now, and we're normally given about half an hour. But I think what you shared is really very applicable to mothers, to babies, and even medicine in general, whatever discipline you're working in. Remember oxygen delivery and circulation in order to ensure that physiologically cells have their needs met. Thank you very much.